Our next panel will be Neuroscientific Approaches to Compassion, and the moderator, who you have met, is John Gillies, and we will begin immediately. If our panelists could go ahead and come up to the podium or to the table here.
We have a very tight schedule this afternoon, so we move swiftly on to the second session, and we have three speakers in the second session scheduled, but as you can see, we only have two speakers on the panel, and that is because our first speaker has actually recorded his talk from Edinburgh. Paul Brennan is a senior lecturer in neurosurgery at Edinburgh University. He's also a distinguished researcher. He won Lancet Young Researcher of the Year in 2014 for his work on stem cells in glioma. He's a valued member of our Compassion Initiative and has contributed very thoughtfully to the way it has developed. So if the technology allows me, then I'm going to just advance the slides. Thank you.
Hello, I'm Paul Brennan. I'm a senior lecturer in neurosurgery and a consultant neurosurgeon based in Edinburgh. I'm sorry I can't be with you in Stanford today, but it's great to have the opportunity to be able to speak with you anyway. I've been involved in the Edinburgh Compassion Initiative since its inception, and one of the opportunities that it's given me is to think about compassion in the context of my day-to-day work as a neurosurgeon and a neuroscientist. So what I want to share with you today is an example of how that process has changed my perspective on something that actually I probably previously took for granted. And I hope that that in turn will have a very positive impact on the patients I look after. So the Oxford English Dictionary defines compassion as participating in the suffering of others, or that feeling, that emotion you get when you see someone else suffering or in distress and you want to be able to help. As a neurosurgeon, I aim to act with compassion, and I hope that the work I do does relieve the suffering and the distress of my patients. What I want to demonstrate today, though, is that compassion in the context of neuroscience and neurosurgery means much more than simply the dictionary definition of compassion. And I'm going to use an example of brain tumours, of treating people with brain tumours, to illustrate this. So my clinical work and my research is predominantly focused on brain tumours. I'm particularly interested in a certain type of brain tumour called glioma. This is the most common brain tumour in humans, and it's also the most deadly, the most malignant. There are benign brain tumours, and these can be treated relatively straightforwardly, and people tend to not have long-term consequences. Glioma, though, is very different. The problem with glioma is that the tumour cells spread throughout the brain. There's no natural barrier that stops the cells spreading. So this makes selecting treatments and giving treatments particularly difficult. So my research is focused on trying to identify new treatments and better treatments. And the strategy I take is really to reduce glioma down to its component parts. So looking at cell signaling pathways, looking at genetic mutations, looking at the behaviour of the individual cells, and using that information to try and design and identify novel therapies. Now, myself and all the other glioma scientists in the world have generated a huge amount of knowledge in this area, but we've really failed to come up with any good, effective treatments. So for the moment, the standard of care for people who have brain tumours is neurosurgery. And as a neurosurgeon, the first question I ask is, can I cut it out? Is this tumour something that I can treat surgically? But you might already be thinking, well, if the glioma cells spread throughout the brain, if those cells are intermingled with the normal neuronal cells, how can you cut that sort of tumour out? And that's exactly the problem. It's hard to define an edge between where the tumour stops and the brain starts, because there isn't an edge. And that begs the question, how do you avoid causing damage, injury to the normal part of the brain when you operate? As a neurosurgeon, when I'm thinking about operating on a brain tumour, I will look at the imaging of the brain tumour and look where it's located in the brain, where the tumour is spread. If the tumour, for example, is in the motor cortex, that part of your brain which is responsible for limb function, or if it's located in the speech and language areas, I might make a recommendation that actually surgery is not possible. And what I'm really rationalising there is, if I can't cure the tumour, if I know that the added benefit of surgery is only a few months or even just a few weeks, I don't want to leave a person paralysed or mute for that time. I'm making the judgment that that's inhumane. What struck me though over the course of the last few months, from the perspective of thinking about compassion, is we don't actually make the same judgment about a patient's ability to be compassionate, about ability to be emotional. This is more than just acting with compassion. This is the question about what it is that makes each of us actually compassionate. Now, I know Dr. Knutson, who's scheduled to speak today, has an expertise in the neuroanatomy of emotional experience. And there certainly are parts of the brain which have been identified as being important in compassion and other related functions. What's clear, though, is that we still don't know enough about the anatomy of compassion and emotion for it to have impacted on the decision-making of neurosurgeons. What's equally clear, though, is that the act of compassion and the ability to be compassionate must be something that is hardwired into the brain. There will be a series of neuronal interactions which are responsible for the way that we act when we are compassionate, the way we respond to circumstances in which we act compassionately. Just in the same sort of way that we now know that memories are formed and maintained and lost through a type of neuronal plasticity called long-term potentiation. And if compassion is hardwired into our brains, then it would stand to reason that there are discrete regions of the brain where we would find the cells that are responsible for those behaviours. What we need to understand then as surgeons is, should we be advocating for the emotional well-being, for the compassion well-being of a patient, in the same way that we try to safeguard their limb function or their speech? If we know that we can't cure a tumour, what is the most compassionate thing to do? Should we be counselling patients that we could add a few extra weeks or a few extra months to their lives, but it might be at the cost of changing the way that they feel, the way that they behave? In those circumstances, what would you choose? Now, the problem is we don't really know what effect that surgery has on the way that we behave, on our ability to be compassionate and our ability to express emotion. We do know that people who have brain tumours feel that there is an impact on their emotional and their mental health well-being. We blame this on the tumour. We blame it on the radiotherapy. We blame it on the chemotherapy. We rarely, if ever, implicate the surgery. One of the difficulties is there isn't a quotient of compassion. It's not something that we can really measure in a very objective way, like limb strength or speech. But if we want to better understand the impact that our surgery is having on compassion, perhaps this is something that we do need to be able to think about how we can measure. One of the main focuses of my research at the moment is on the diagnosis process in adults with brain tumours. Now, this is a research priority both for patients and for funders. The problem is that the symptoms that people often have when they first get brain tumours tend to be quite non-specific. So physicians and family doctors find it quite difficult to prioritise who needs urgent imaging. Our approach is to analyse clusters of symptoms and try to identify patterns that we can then use in future to prioritise the people who need investigations before others. The aim is to diagnose brain tumours earlier, when they're smaller, when they can be treated surgically more safely and hopefully more effectively to improve outcomes. We'll also want to reduce the stress of the delayed diagnosis, reduce the stress of the uncertainty of knowing whether or not if your tumour had been picked up earlier, you would have done better or would have survived longer. Striving to reduce the time to diagnosis is clearly compassionate, but what I hope I've demonstrated today is that there's more to compassion than this. When we think about operating, we are quite literally at the cutting edge of compassion. And that's why we're combining this research on diagnosis with looking at the emotions and the compassion of patients both before and after surgery, and correlating this with the region of the brain where we're doing the operating. We hope in future to be able to provide patients and their families with more information so they can make a more informed choice about whether they want surgery and the type of surgery they want. So I hope I've demonstrated that the Compassion Initiative has given me an opportunity to bring together the different worlds of neuroscience and neurosurgery in order to innovate new ideas for how we look after people with brain tumours. I offer you the challenge of looking at your own work and your own expertise and seeing whether compassion can change your perspectives and perhaps even change the way that you interact with other professionals around you. The great thing about compassion is it doesn't define a particular ideology, a particular body of knowledge or a political view. It's something that we all have experience of and something that we can expect anyone we meet to have some shared understanding of as well. Compassion is non-denominational. It's a great leveler, it's very egalitarian, and it helps us to transcend some of the barriers to communication and collaboration that we come across in our everyday lives. Hopefully then a focus on compassion can lead to new ways of working and new ways of thinking, innovating and hopefully changing things for the better. Thank you very much for listening. Good afternoon.
Thank you very much, Paul. It's very hard to say thank you to someone who's actually not here at all, but I still feel I have to say that. And the compassion journey of the initiative has been one that's affected all of us. Before we started this, and it was really only July last year, I would never have thought of neurosurgery and compassion as having any sort of close connection, but now it's obvious that neurosurgery is at the cutting edge of compassion. So thank you, Jim, and thank you, Paul. And Paul has raised a lot of really interesting questions there about providing person-centered care for patients with serious brain tumours. We'll move on, because time is short, to our next speaker. Paul is from Edinburgh. Our next speaker is from Stanford. Professor Brian Knutson is Associate Professor of Psychology and Neuroscience, and he has done work on elucidating the neural basis of emotion and exploring the implications of this for psychopathology and decision making. No small things. Thank you, Brian.
Thanks for the opportunity to be here and the invitation and the kind introduction. I do work here at Stanford. I can blame and praise Jim Doty and CCARE for allowing me to be here. They've gotten us interested in the topic of compassion, which is admittedly scientifically non-trivial to study, especially when one throws the brain into the mix. But what I'd like to do today is just briefly describe some of our efforts, which are supported by CCARE, and in collaboration with Thupten Jinpa, who is a scholar, a Buddhist scholar in the Mahayana tradition, to try to elicit compassion as people are being scanned, and also to understand whether eliciting compassion can have a lasting impact on how they interact with others. And I'm just going to describe some very early data. This is research in progress, so any feedback will be welcome later on in the conference here. Now, I should preface this by saying that in my field in which I was trained, psychology, compassion is often thought of as sort of an emotion, sort of a categorical emotion that people feel, albeit complex, that has various sort of physiological profiles and effects on behavior. But I have found in my interactions with Jinpa that the Buddhist way of conceptualizing compassion is extremely useful for two reasons. One is they think, as far as I can tell, of compassion as sort of a process. So it's sort of an unfolding of various processing steps that occur. And as you're going to see, this is going to be useful for trying to visualize what's happening in the brain. And they also have crystallized these steps into a series of trainable practices. And so we can ask people to go through these steps as they're being scanned and observe what's happening in their brain. And so what are these steps? Well, this is a very lay summary of how I understand Jinpa's steps derived from the Mahayana practice of Tonglen meditation, of cultivating compassion. So the first step is that you cultivate concern for a person. That means you care about them. Often it involves identifying with a person. And so the typical example Jinpa gives is your mother. So that your mother, in order to care for you as a baby, probably identifies with you as part of her. So really as part of herself. The second, and you might identify with your mother, at least at a young age. The second is that you appreciate the suffering of the other person. Now, this is a Buddhist definition, but the idea is that you recognize that they're suffering. And the third, which is not always part of the Western definition of compassion, is that you wish for them to be free of the suffering, and sometimes you act on that wish. So if it's appropriate, you act to remove the suffering from them. And so even though this sounds kind of didactic and very operational, it helps us then to craft an intervention, if you, I wouldn't even call it an intervention, but a manipulation that we can ask people to perform as they're being scanned and try to understand what's happening in their brain and then whether that has some lasting effects on people. So here's a very simple example of an experimental task design that we have run in the magnet and also behaviorally, in which we'll show people a cue. It could be a triangle or a square, for instance, and we instruct people that these different cues mean that you should do different things when you see a stranger's face coming up. Either you should extend compassion, so through those three steps that I just described, identify with the person, recognize their suffering, wish for them to be free of it, or extend a neutral feeling to that person. So don't identify with the person, don't recognize any suffering, and don't wish to do anything about it. So we have people do this on various trials. It seems kind of strange, but people get the hang of it, and then they can rate actually how effectively they thought they follow these instructions in each trial. So we can get a sort of a moving measure of their self-perceived effectiveness. And they do this for many trials with different targets, different instructions, and so forth. This allows us to get measures of what is the brain doing as they're actually viewing this person's face and either extending compassion or neutrality. Thanks. And so the other reason I like these instructions is because it gives us targets in the brain. So based on some of the studies that have been done in neuroscience, we have targets for a cultivation of a sense of concern or identity when people are thinking about themselves or those closely identified with them. We often see activation in the medial prefrontal cortex. We can get into those details later offline if you want. When people are considering suffering or feeling suffering for themselves, you often see activity in parts of the brain like the amygdala and the anterior insula. You might say deactivations in parts of the brain implicated in pleasurable feelings. And then if people are moved to do something, to take action, we often expect there to be activity in a part of the brain that's associated with the preparation for motor action and perhaps even the motor cortex. If we do a simple contrast of these two instructions, what we do see is that in many of our target regions, including those associated with identifying with another person, with perhaps imagining their suffering, and even preparing for action, we see significant activity. Now, this varies from person to person. This is a group statistical map. But this just illustrates that we can try to break down compassion using the Buddhist definition and reconstruct it using neural activity. Now, the real question, in my mind at least as a researcher, is what is the behavioral consequence of this? And I'm not going to have time to get into the details there, but I will tell you we do see very interesting behavioral consequences of this, not all of them intended. And so we have measured actually after this induction people's responses to associated stimuli. So we'll show them the targets to which they extended compassion or not, and then show them, after we show those stimuli, an abstract painting or a piece of art or something like that. And we'll say, how do you feel when you look at this piece of art? Don't worry about the faces. How good or bad, how aroused, and so forth. What we see is a consistent shift that they regard the art associated with the faces to which they extended compassion more positively. This works whether they actually consciously see the face or whether we subliminally present the face before the art. So there seems to be some implicit trace associated with this very simple practice in college undergrads of extending compassion that makes things associated with that face seem more positive. And we can even see traces of this in the brain activation. So we scan people while they're looking at this art and judging it. We see more activity in areas associated with a positive response to things. And so that's what we're writing up, and I'm not showing much of it because I'm out of time. But I think these preliminary findings are encouraging, at least to me as a scientist, because they suggest that even simple exercises of extending compassion can recruit neural circuits that make sense to us as neuroimagers, that are implicated, and you saw they're all over the brain, as the previous speaker implied, in identification, emotion, and possibly in action. And we also think that just doing the simple exercise, which really could be put on an iPhone app, induces some lasting positive traces or associations that we can track behaviorally and even neurally. And that, of course, will lead to the question of, like, okay, this is just undergrads in a magnet for a few minutes. What about people who really practice this, who really do related are the Olympians of compassion? And so eventually, if we get the right probes, then we'd like to investigate those people as well. So I'll stop there because I'm thinking I'm out of time. Thank you.
Thank you very much, Brian. Another perspective on compassion from another discipline. We have another Stanford speaker now, Professor Firdaus Dhabhar, who is Associate Professor of Psychiatry and a member of the Cancer Institute, who's studying the effects of stress on immunity and health. Firdaus.
Thank you. I want to start by thanking Jim and Monica for putting this meeting together and giving me a chance to share some thoughts with you. And also a warm welcome to our visitors from Edinburgh as well as Finland. A warm, sunny welcome, thankfully, that we have for you. So the major focus of my laboratory's research, we conduct basic as well as clinical research in my lab, and our major focus is to try to understand how we can maximize and optimize the body's defenses to enhance immunity during surgery, wound healing, infections, vaccination, and some types of cancer. And one major angle that we work on is stress, which is what I will share with you today. And then towards the end of about 8 minutes, try and connect with the concept and the focus of our meeting today on compassion. So why stress? Stress impacts everyone. It impacts folks who are fortunate enough to be healthy. It impacts folks who are unfortunate to be sick. Patients, and when someone you care about is sick, it also induces a significant amount of stress on their friends and loved ones. And so we believe that it's quite an important and useful thing to study. And 2 years ago, when Jim had invited His Holiness the Dalai Lama, and thanks to Jim, we had a small private meeting with him, my colleagues Dan Martin and some of the others who are in this audience. His Holiness was speaking with us, and a lot of what he said to us about was actually stress, and had some very thoughtful things to say about it, so much so that Dan said to me after the meeting that, did you pay him to do that? And I said, no, he doesn't do that kind of thing. So, all right, so what is stress? Definition's very important. We define stress as a constellation of events that begins with a stimulus, the stressor, that precipitates a reaction in the brain. So this is stress perception and evaluation that then results in the activation of fight or flight systems in the body. This is your biological stress response. And it's absolutely critical to understand that without a biological response, it doesn't really matter to the body what happened in terms of stress. So you absolutely need a biological response with various factors getting activated in order for stress to exert effects on the body. Now, early on, we discovered that dividing stress into two broad categories was very useful. So we specifically divided stress into short-term stress as well as long-term stress, and we specifically defined short-term stress as those stress-related responses that last for minutes to hours in duration. This is the reason why Mother Nature gave us the stress response. This is Mother Nature's stress response. We define chronic stress as stress responses that last for weeks to months to years on end. And this is bad stress. This is the more well-known big brother of stress. And this is not the reason why Mother Nature gave us the stress response. This is the expression of a biological stress response the way it was not intended to happen by Mother Nature. Now, it's important to keep in mind that a stressor can involve a threatening situation or a challenging situation. So a prototypical stressor would be a predator. But intensely challenging situations, such as performing where it significantly matters, making a very important speech, going for a very important interview, running a very important race, playing a very important game, or even exercising when you choose to exercise and you love to exercise, induces a stress response that is very similar to that induced by a stress-inducing agent such as a predator. In fact, excitatory stimuli, such as approaching someone for a first kiss, especially when the person doing the approaching is romantically challenged, can actually simulate a biological stress response that's very similar to that induced by a lion. Sexual intercourse actually is a very potent stimulator of this response. So the point is that Mother Nature's stress response is not only activated under conditions that are threatening, it's also activated under many, many other conditions where we need to perform. So we initially showed that short-term stress responses, if activated in conjunction with immune responses, significantly enhance those immune responses that occur contemporaneously with that short-term activation of the biological stress response. So one way in which there are many different mechanisms that we work on, but one way in which short-term stress accomplishes this is by stimulating the body's soldiers or the immune cells to leave their barracks, which are organs like the spleen, enter the boulevards of the body, which are the blood vessels of the body, and then move on to take up positions at potential battle stations in the body, of which the skin and the skin-draining lymph nodes are examples. So this is one way in which Mother Nature's stress response, the hormones and factors released during stress, orchestrate a defensive position for the body to prepare it for trouble or challenge. So examples very quickly in which we sort of try to use this in the clinic is that we've shown that, for example, patients undergoing surgery, amongst patients undergoing surgery, those who can mount Mother Nature's adaptive stress response in response to the process of undergoing surgery itself can recover much faster and much better from surgery compared to those patients who fail to mount that response. And we are working on ways in which to understand this better and to create the response, the beneficial response in patients who may not be able to mount it. And Jim and I hope to start a study soon to sort of look into this further between the two of us in our labs. There are other examples that I can go into offline later on if there are questions, but just so that you understand, one of our major goals then is to understand the ways in which Mother Nature maximizes defenses, to understand the way in which Mother Nature's good protective stress responses work, and then to harness them in ways that would be beneficial, either in a clinical context or in a day-to-day performance context. All right, but there's another side to stress, and that is bad stress. Chronic stress, which we specifically define as lasting for weeks to months to years. And unfortunately, we humans are rather good at causing bad stress for ourselves and for others. Now, chronic stress has been shown to suppress wound healing, suppress vaccine responses, suppress certain responses that would protect us from diseases like cancer. Chronic stress has also been shown by my colleagues and on my lab as accelerating biological aging, which dysregulates cells and sets up conditions that would create further potential problems in terms of health and well-being. Chronic stress is also known to suppress creativity, productivity, and many, many aspects or dimensions that would involve sort of normal day-to-day living in a productive manner. In fact, the cost of job stress alone in the United States alone has been estimated to be $300 billion a year. So there's this bad side to stress. So how do we deal with stress? Well, it's a work in progress, but what I have proposed is this concept of the stress spectrum, which goes as follows, and I'll tell you how compassion relates to this. On your left, just imagine a spectrum going from left to right. So on your left, you have acute short-term stress. This is good stress. This is the way Mother Nature intended the stress response to work. On the right-hand side, you have bad stress, which consists of chronic stress, depression, burnout that Liz mentioned in the first presentation today. And in between the two, you have your green zone of low or no stress. What you want for good health is to minimize that bad stress, burnout, inducing stressors, optimize your short-term protective stress response so that you mount it robustly when you need it and then shut it down as quickly as possible. And you want to maximize that green zone of low or no stress as far as possible. So how do you do it? It's easier said than done, but these are the factors that we are working on. The first bank of factors, we believe the 3 bank of factors can enable you to get to an ideal stress spectrum. So the first bank involves lifestyle, and I'll just quickly mention these for lack of time. So sleep, It's extremely important. Physical activity or exercise and nutrition in moderation could be one bank of factors that enables you to optimize that stress spectrum. The second bank of factors involves psychosocial factors. These involve working on issues of appraisal, coping, mechanisms by which you evaluate and reject stress responses before you get a biological response. Social support seems to be a very important factor in buffering against the bad effects of chronic stress. Authenticity, so genuineness, appears to be key. Gratitude and compassion. And social support and compassion I'll mention a little bit more right at the end of my presentation. And then finally you have the third bank of factors, which is the activities, which could be meditation, yoga, mindfulness, nature walks. You got it. It doesn't have to be contemplative, so if you can't levitate, no problem. You could dance, do music, art, fishing, painting, breathing. Whatever enables you to optimize that stress response is what would be good to work. And if one does this in terms of an effective optimization of their stress spectrum, one is likely to see benefits not only for enhancing immunity, which we work on in the lab, but also for enhancing cognitive physical performance, increasing health, hopefully also happiness and well-being. So I just want to end very quickly in terms of some of the factors of social support and compassion beginning to show how actual molecules, biological entities that mediate these equations between good and bad stress can be changed positively. So there have been studies by Pace and colleagues that have shown decreases in stress-related factors, both baseline as well as stress-induced decreases in stress-related inflammatory molecules following a compassion-based intervention. Similarly, studies with Rakel et al. Have shown that receiving compassion from a physician significantly enhances resistance to the common cold, so the rhinovirus-induced infection. And then we have several studies from colleagues at CCARE, including Dan, that suggest a reduction in the bad stress-related factors with compassion-based approaches. Monica I realized, wrote a recent piece in the Huffington Post that talks about this in a very nice way, dealing with workplace issues and compassion-based approaches. And then I think finally Jim's book is a wonderful example of the amazing things that can happen when, as he says, the mind and heart can be made to work together in the right way. And I think a wonderful example of how I'd say a chronic stress, bad stress situation has been converted into the amazing things that you have done. So thank you very much, and I'd be happy to talk about things later. Thank you.